Okay. Hello, everyone. Welcome and thank you for joining us for our discussion on the South Sudanese Women Intellectuals Forum. My name is Dr. Anne Lomole. I'm a pediatrician and infectious disease consultant, and I will be your moderator. Today, as the world marks World Diabetes Day, we will be discussing non-communicable diseases with a focus on hypertension, asthma, and diabetes. Non-communicable diseases refer to diseases that are not passed from one person to another and are of long duration. The 2030 Agenda for the Sustainable Development Goals recognize non-communicable diseases as a major challenge for sustainable development. They impact productivity and are expensive to treat. According to the WHO, non-communicable diseases are now the leading cause of death in the world, representing about 71% of all annual deaths. About 85% of these deaths occur in low and middle income countries, of which South Sudan is one of them. Around the world, they affect both men and women equally with a few variations. Some of the most common non-communicable diseases include cancer, cardiovascular conditions like hypertension and heart disease, lung conditions like asthma and chronic obstructive pulmonary disease, and diabetes. This contribute to about 80% of all the deaths related to non-communicable diseases. Non-communicable diseases are largely preventable, and some of the most effective interventions tackle modifiable risk factors, for example, unhealthy diets and physical inactivity. In view of the impact in terms of mortality and morbidity, it is therefore important to discuss these diseases, to identify risks, factors, causes, and prevention strategies, and also to discuss the challenges in treatment, the importance of follow-up, and possible recommendation. Today, I would like to welcome our panel of experts who will be speaking on various aspects of non-communicable diseases. We will focus on definitions, statistics, diagnosis, and treatment. Our panelists will also discuss consequences and the importance of follow-up of these diseases and danger signs to look out for. They will also discuss challenges in management and give recommendations. I would like to thank our panelists who have joined us today for taking their time to share their experience and knowledge on this platform. I would also like to thank the audience for joining us on this live discussion on YouTube and Facebook. Please feel free to share the link on all your social media platforms. Don't hesitate to ask any questions on our wall, and we will try to answer as many of them as we can. For those we are unable to answer, our panelists will get back after the discussion and answer them. We would also like to thank the UN Women for their support, and Aisha, who's behind the scenes right now for technical support. And for now, I will go straight into introducing our panelists today. Dr. Jane Abucha, I will start with you. Dr. Jane Abucha is a professor of nursing and a clinical and classroom instructor for the Carrington College of Nursing Associate Degree Program. She earned a degree in 1988 as a nurse practitioner, and therefore has many, many years of experience, and prior to moving to the US, a degree in medicine. In the US, had 2 degrees, however, were not recognized, and therefore she had to go back to school and later earned a bachelor's degree in nursing science and a master's degree of science in nursing with a specialty in acute care as a nurse practitioner from the Grand Canyon University. She currently holds a doctorate in nursing practice, and as you can see, she has many, many years of experience in the profession in various capacities. Welcome, Dr. Jane. Next, I would like to introduce Dr. Sarah Bullen Alier, who is a Premier Medical University trained doctor with experience in pediatric and child health education. As a physician and a medical instructor, she tries to close the existing gap of cultural diversity by using her cultural advisory, advocacy, and communication skills in different languages. She has a passion for healthcare, especially in underprivileged societies. Thank you, Dr. Saren, for joining us. Next, I would like to introduce Dr. Linda Fandasi. Dr. Linda holds a bachelor's degree in medicine and surgery from the University of Juba. She is the founder and owner of Safe Care Medical Center in Juba, where they offer both generalized and specialized services, laboratory, pharmacy, and imaging, inpatient and outpatient care, with dedicated and qualified personnel who have vast experience and expertise in the field of medicine. Dr. Linda believes that patient care should be a doctor's first priority, and she has built her medical career with this as her driving force. Welcome, Dr. Linda. Next, I would like to introduce Dr. Kiden Annette, who is an obstetric and gynecology registrar at the University of Nairobi, currently doing her master's in medicine in obstetrics and gynecology. She has an undergraduate degree in medicine and surgery from the Kampala International University, and she has a passion for women's health. Welcome, Dr. Kidin. Next, I would like to introduce Dr. Chuti Yot. Is a graduate of Juba University School of Medicine. She trained initially in Khartoum in Sudan and completed her internship in Juba Teaching Hospital in South Sudan. She then worked at Juba Teaching Hospital as a medical officer in the Department of Internal Medicine for 2 years. However, she decided to go with the children, and she is currently doing her master's in medicine in pediatrics and child health at the Kenyatta National Hospital in Nairobi, Kenya. Thank you so much, panelists, for joining us today. In the interest of time, I will go straight into the questions, and I will start with Dr. Jane. Dr. Jane, if you can please unmute yourself. So Dr. Jane will set the stage for us, and she'll be discussing mostly everything, mostly about hypertension. And she'll set the stage right now by defining what hypertension is and maybe giving us an overview of how we tell that a person has hypertension. And if you can also delve into some of the statistics and compare South Sudan, if they're available, with Africa and the world. And let us know, do the figures vary? And if they do, why? Thank you, Dr. Jane.
Good morning, everybody. Can you hear me?
Yes, we can. Yes, we can, Dr. Jane. Go ahead. Thank you.
Okay. Good morning. My name is Dr. Jane Abucha. I live in the state of Arizona, and I'm a South Sudanese. Prior to coming to United States, I was a nurse at Juba Teaching Hospital. I was an RN since my first job as an RN was May 11, 1988. And working through there, I went to HTN, Khartoum, got my diploma in medicine, practiced there for some years, moved to Egypt, and moved finally to United States. Today, I will be focusing mostly on hypertension because I've seen a lot of people like pediatrician. No offense, I had 7 kids myself. I'm done with that. Can't stick around with kids anymore. So I am doing adults. I do see kids in my clinic, but I do not see kids younger than 5 years because I do not want to carry vaccines in my clinic. So that's by my choice because I do not want to carry vaccines in the clinic. They're costly, taking care of them are difficult, and I have to pay for them. So I do not want to carry the vaccine. So I do not see any child younger than 5 years in my clinic. So I will be mainly focusing on adult. So let's talk about high blood pressure, which we call hypertension. What is this high blood pressure? We define blood pressure as cardiac output times systemic vascular resistance. So when we measure blood pressure, we are actually measuring the resistance of the blood pumping against gravity. So that's what we call cardiac output times systemic vascular resistance. So there's many factors that affect blood pressure, factors that affect cardiac output, like things that affect the heart rate and affect the contraction of the heart. We have also factors that affect circulation, which include volume circulation from salt or aldosterone hormones. We have another section of things that affect blood pressure, which includes hormones that are vasodilators. So, and we have hormones that kind of dilate the blood vessels or constrict the blood vessels. And these ones are treated herbs. We have groups that are affected by the peripheral sympathetic receptors, which constrict also or dilate. And this also cause blood pressure. And these ones are treated by alpha receptors, alpha blockers or beta blockers. Then we have those that affect the CNS and locally. Why is this important? This is important because it will help us define what the blood pressure is, understand what the blood pressure is, and choose an appropriate medication to treat blood pressure. Now, there are several types of blood pressure, mainly categorized as two types of blood pressure. There is idiopathic blood pressure or essential hypertension, or you can call it primary hypertension. We have those that are resistant to blood pressure medication. We call them malignant hypertension. Those are blood pressure that are resistant to one or two medications, and we have to employ more than two medications in some cases to control the blood pressure. And how do we define these blood pressures and divide them? We have that essential and primary hypertension. We also have secondary hypertension. Secondary hypertension, these are caused by secondary things. And then within the secondary problems that raise high blood pressure are like renal artery stenosis, RAS. Renal artery stenosis affects men and women, but more in women around the ages of 50. And this is also multifactorial. Now, when we talk of high blood pressure, what kind of blood pressure are we talking about? We're talking about blood pressure that you measure. Either you go to a kiosk, you check it, you go to the hospital, they check your blood pressure. The top bottom, if it is greater than 140 consistently, we say you have high blood pressure. Or the bottom part, if it is greater than 80 consistently, we say you have blood pressure. Presentation of the blood pressure differ. It can present in a pre-hypertension, in a primary physician setting that you can monitor over time. A person can come with stage 1 hypertension where the blood pressure is already greater than 140 over 90 without any target organ damage. When we say target organ damage is that when this person presents with blood pressure, something else in the organs are affected. Either the patient's eyes are affected, the patient's kidneys are affected, you check the microalbuminuria, something is affected. So there is something additional, which is a complication of that blood pressure happening in another organ. So we say that one is hypertension plus target organ damage. When we diagnose blood pressure, we do not see a person one time and diagnose it with blood pressure, unless the person has target organ damage. Blood pressure is diagnosed basically a lot of times in the primary settings, and sometimes it's diagnosed when patients come to the hospital with very high blood pressure and especially complications of the blood pressure, which are target organ damage. Even patients that present with stroke, we now see younger people, even of age 17, present with stroke. Let's talk about South Sudan. Where are we in the map? We're in the map on the Central Africa. Some say we're in the Eastern Africa. Some say we still lie towards the North Africa. Everybody is confused about South Sudan. But bottom line, South Sudanese present with a lot of blood pressure issues, just like any other African country. Looking at data, a lot of South Sudanese that present with blood pressure have either been caught accidentally when they showed up to hospitals, or they showed up for something else, or showed up for complications or heart attack or a stroke. Very few of them, or rarely do they present to the family doctor to be checked and assessed for blood pressure. But looking at data, South Sudanese have about 19 to 20% issues with blood pressure in their population. This is only data that has been documented. There are data that have been documented in Khartoum that shows up to 30% of possible South Sudanese could have blood pressure. Uganda has about almost 30%. So that's our neighboring countries, and they have a lot of similarities to what we do have. So looking at this, we can say that if 20% of the population have high blood pressure is a problem. And if we know that 20% of the population are the only people who present to the hospitals or the clinic for blood pressure, there may be a higher prevalence of blood pressure that has not been assessed, that we do not know about. And that is the bigger picture that needs to be understood and needs to be addressed. Hopefully in the nearest future, somebody will develop an interest and go in there and make a better assessment. How does blood pressure present? It presents in male and female the same. These days we have a lot of younger people that have blood pressure as well. Among the South Sudanese living in diaspora, there is 1 in every 3 adults over the age of 40 have hypertension. It's more in female than male that I have seen here in diaspora. So going to the questions I have. The first question is asking the difference between the sedentary life and hypertension. And what is the relationship with activity? I can tell you how many times we try to answer this question, and it is almost impossible for some groups and almost very understood in some groups because of awareness. Sedentary lifestyle is a lifestyle that...
Dr. Jane, as you talk about the sedentary lifestyle, you could also add on some of the risk factors, both the modifiable and non-modifiable ones.
Sedentary lifestyle is basically I wake up in the morning, I shower, somebody brings my breakfast, I eat, I dress up, I go to work, sit in the office, turn around like those good people, Maftamingis in Juba, and then at 3 o'clock, I go home, I wait for my wife, bring the food, I eat, and I lay down. So that's just an example of a sedentary life. And people who have that kind of lifestyle, who have no prior history in their family of high cholesterol or high blood pressure, may have blood pressure in the longer time. But those kind of lifestyle comes with a lot of risk factors carrying it around, including the inactivity, the diet. The diet part is huge because not only eating other foods that may be rich in fats, but foods that may be rich in calcium and food that may be causing more problems than you do, like lack of antioxidant, lack of other minerals, and lack of other vitamins to even support yourself, support your immune system. So you're eating food that is available or a luxury type of food that you really want because you can afford it, but not balancing out your diet. These kind of things result in obesity, result in atherosclerosis, and it results in more multifactorial issues. Multifactorial issues, that means a lot of issues that are created by environment and food and lifestyle. And this can result into high blood pressure. Increasing activity, modifying the diet, which is called therapeutic lifestyle modification, can allow you to live longer even if you have that family history of high blood pressure in your family or high cholesterol. Stress and high blood pressure. What is the relationship? There is a huge relationship in stress and high blood pressure. I just said earlier that among the women in diaspora here, more women have high blood pressure than men. Why? Because of stress. The increased stress creates that resistance in your blood pressure. And that resistance pumping against gravity that creates blood pressure can also create other problems in your life, including migraines, constant of feeling sick, target organ damages, and reducing stress and reducing the environmental impact from the food you eat. Not to mention, we have really good cooks in South Sudan. Our women cook really nice food. But that's a problem in our life. Very, very much. عشان لحم كروف بقى راجل كنا نجيب كروف ركبوا عمل شنو. It's a recipe for strokes. It's a recipe for target organ damage. It's a recipe for heart failure. It's a recipe for kidney transplant. So the diet of everything that we eat, because we are stressed, we don't have time to cook. We are just passing by a McDonald's. We're just passing by Burger King. We're just passing by Kentucky Fried Chicken. It is okay to eat that once in a while when you don't have time to order pizza for the kids and do that. But it is a type of diet that does not help if your history or your background has blood pressure issues, even if you know it or you don't know it. Activity and therapeutic lifestyle modification helps a lot.
Thank you so much, Dr. Jane. I think we'll go back into more of those risk factors. I think you, for now, in view of the fact that you have talked a lot about the modifiable risk factors in terms of lifestyle and physical inactivity, right, we can go to Dr. Linda and she can try and also set the stage for us in terms of diabetes, and she will also be able to...
Let me knock out one thing here.
Yes, Dr. Jane.
There is a myth that sugar and salt intake can balance high blood pressure. I do not know where this comes from, but none of those can help. None of those can help. Therapeutic lifestyle modification is a combination of activity, low fat, low carbs, low cholesterol, which is cardiac diet, is what can help you control blood pressure without medication, not the low salt, not the sugar and salt intake balance.
Thank you, Dr. Jane. I think it's important for us to also talk about some of these myths that people have out there that really don't contribute to the management of these conditions. And yes, you're very right about that. And we need to be able to dispel some of those myths so that we can be able to educate our communities in order for them to be able to take care of themselves much, much better. And yes, lifestyle modification and healthy diets are an important part of the management of some of these chronic non-communicable diseases. So Dr. Linda, the next question is for you. Can you please define for us what diabetes is and the different types of diabetes and what the difference is between those types? And if you have any statistics for South Sudan, Africa, and the world, if you can compare and tell us why the reason for the differences, if there are any differences. Then maybe you can also go a little into some of the risk factors for diabetes and the causes and what we can do to prevent, and some of the myths, as Dr. Jane also went into some of the myths that she wanted to dispel. Thank you.
Good evening, everybody. I'm Dr. Linda Fandasi. As today is World Diabetes Day, I'm going to take this opportunity to spread awareness and education on how to diagnose the diabetes and how to treat it and how to prevent it. Back to the question. By definitions, diabetes is a chronic disease that occurs when the pancreas is no longer able to make insulin, or there is a resistance of the body to use the insulin that the pancreas produces. So the insulin is play a very important role to take the glucose that we ate it. We get it through the food that we're taking it, like carbohydrate foods and protein and lipid. Usually those food is break down into the body, into the glucose. So the insulin is play the role of taking this glucose to inside the cell. When there is a defect, it leads to the increase of the blood glucose level in the body. For the types of the diabetes, there are many types of diabetes. The common three types of the diabetes. We have type 1 diabetes, and it's also called insulin independent diabetes. And we have type 2 and gestational diabetes. Type 1 diabetes is an autoimmune disease. The immune system, it attack and destroy the cell in the pancreas. So where the insulin is made of. So the exactly cause unknown. So we don't know how this immune system attack the pancreas. Actually, nobody knows. So it happened when it destroyed the pancreas cell, so it cannot able to produce the insulin. And this type 1, it can present at any age, but most frequency in children and adolescents. And someone with the type 1 diabetes usually is depend in the insulin in the treatment. For type 2, it results from combination of the insulin defect and insulin resistant. So this one are more common in adults, and it is represent of 90% of type of diabetes. So the patient that has the type 2 diabetes, usually, so for treatment, it depends on diet and oral hypoglycemic drugs. For the gestational diabetes, this type of diabetes, its diagnosis usually during the pregnancy, when the blood sugar usually go high during the diabetes. Most people are high risk for the diabetes during the pregnancy. The overweight people, those the obese people, or the woman usually when she get pregnancy, she add more weight than the normal. So those women, they're the one commonly in the high risk of the getting diabetes. And when they're getting diabetes, they usually complicate it with the problem affects mother and the children together. So the statistic for South Sudan, actually, we don't have a specific statistic for South Sudan because our center here is not active. They just open a center and leave it like that. It's not active, actually. So I don't have a specific statistic for South Sudan. What are the causes and the risk factor? There is a different causes are associated with each type of the diabetes. For type 1, usually it's result from the autoimmune disease, so the exactly causes unknown. But some risk factor may lead to the type 1 diabetes, like genetic factor, and a child of an insulin-dependent parent is more common with the father. If the father has insulin-dependent, mostly from 30 to 35%, the child may develop type 1 diabetes. And viral infection also, the viral can attack the pancreas cell, and the pancreas will not able to produce insulin. Also the immunological factors. So it also may be the risk factor for the type 1 diabetes. For type 2, it's the result for combination, as I said before, of the insulin defect and resistance. The risk factor for it is overweight. Those people of adding weight, the people like to add weight, and those obese people. And the age, mostly from 24 to above, those people are at high risk of getting type 2 diabetes. And also family history. If you have family history, you have to go always for a check. And people with high blood pressure also, they may develop later on the type 2 diabetes. So for the gestational diabetes, it's result from the hormone that change during the pregnancy. So the risk factor for it is the weight, overweight. So the pregnancy woman should control her weight by doing exercise and eating healthy food. So the prevention for diabetes. Type 1 diabetes is not preventable because it's an autoimmune disease. But type 2, some risk factor, we can prevent it, like overweight and obesity. We can do fitnesses and adjust our diet by eating healthy food. So this one can help us to prevent the complication. For example, also we can do exercise by walking, by cycling. This all can help us to reduce the risk factor for the complication. Also, we have to eat more fruits and vegetables. These are healthy food that can help us to reduce, and food with low fat also. It helps us to reduce the risk for the complication. How we diagnose it?
Thank you, Dr. Linda. We'll go into diagnosis a little later. And thank you for explaining to us the different types of diabetes. I think Dr. Kiden will go a little bit more into the details of diabetes in pregnancy. And then before that, you, of course, also set the stage for what the diagnosis is. Now, in terms of statistics, I think this is something that Dr. Jane has also talked about, the fact that our country now coming out of a post-conflict, sort of a post-conflict situation at the moment, some of our institutions are not really set up to do the research at the moment, but that is something that we would encourage all health professionals to get into. Some of the data that's out there is about a percentage of about 10.2% according to the World Diabetes Atlas. That was in 2019. But as Dr. Linda has indicated, that there's no ongoing very serious collection of data, but I am sure that if we can get someone from the Ministry of Health later on board, they'll be able to tell us what the Department of Non-Communicable Diseases is doing. Next, we will go to, thank you, Dr. Linda, also for talking about some of the causes and the risk factors. I think they seem to have similar risk factors with hypertension, which Dr. Jane Abucha has also mentioned. And of note is that you indicated that type 1 diabetes is insulin dependent, and it's mostly because there's destruction of the cells that produce insulin. Thank you for that. So next we will go to Dr. Sarah. Dr. Sarah will set the stage for us and discuss a little bit about asthma and any statistics available on asthma, whether it's South Sudan, Africa, or the world, and also tell us a few details about what causes asthma, what are the things that worsen it, and what are some of the things that people can do to prevent exposure to some of these triggers, and what are some of the myths that have been associated with asthma. So define asthma, give us a few of the statistics, the causes, the triggers, and how to avoid exposure, and some of the myths. Thank you, Dr. Sarah.
Okay, thank you very much. And thank you for having me. And I greet you all, the rest of the doctors. And I'm glad to be with you to help our people and to help whoever will come and join us today and listen to what we are saying. And I will simplify what I'm talking about because I know I'm talking to people who may not be able to pick up the book and read about what is happening to them. So I will simplify as much as I can. So talking about asthma, so I'm not going to use medical term, only if something that I don't know how to simplify. So we need to think first that who are we when we're talking about asthma? We need to know that we are not alone in our body. Our body is not for us alone. We have some bacteria that live within us. That's number one. Number two, we need to know that when we make our body, we come out of somebody's body. So that's the most important thing that we need to put in our mind. Now, if we come to the asthma, saying those two things, asthma is a disease of the air. Yes.
There's a bit of echo on your side.
Oh.
If you have another device on, you can please put it off. Use one device on.
There is no device that is have a voice on here.
Okay, great. Just go ahead. Hear you clearly now.
Is it still or?
Yes, just go ahead. It's more clear now.
Okay. Is it better now? Okay, because it's probably my hands on the table. Okay, so as I was saying, so the asthma is a disease of the airway. The airway, which are the one, is how you breathe. That's your problem there. The breathing is your problem. So there is something that is called COPD. And I'm not going to say what it is there because it's not important for you listeners right now. What is important is there are three diseases that can look alike, which is something that is called asthma, something that is called bronchitis, and something that is called emphysema. They will look alike as if they are the same thing. But at the end, the problem is how the air move in and out. So let me just do this, like I'm putting my hand like that, okay? I'm making a hole like this in my hand. In that hole, that's where your air will go in and out. Now, if you are asthmatic, your problem is that hole is getting smaller. So now, to get the air in, it may be easier, but to get the air out, it will be a problem. So this is the problem of the asthmatic people. So how can we know that these people are asthmatic? I'll come to that one in a short term, but let me say this. People say the asthma can be for the people that is inherited. It is true. You can inherit it from somebody. But there is asthma that you can get just because it's you, not because you're inheriting it from somebody. So it can come from the environment where you live at. Now let me go to when you are being born, because when you are being born can be a problem in you getting the asthma, because there is two ways that the child can be born. You can be born in a natural way, or you can be born by a cesarean section. So when you come out of your mom give you some of those people who live in her, the bacteria I told you earlier, the bacteria that live in the mother give you a gift of those ones. And number two, the mother will breastfeed you. As she breastfeed you, you will get some help from that mother. So those two things are important in helping you later on whether you will. And this is a new information, by the way. It will help you whether you're going to get the asthma or you're not going to get. So my advice here, for those people who are talking about asthma, breastfeed your child. Because you breastfeeding your child, you're helping them. I know I'm talking about treatment right now, but let me just go as we go. So you breastfeed your child, you protect them from the future. Even if you are somebody who is coming from the family that have asthma, so you're going to help them, because when you breastfeed them, you give them more strength, and how likely they will develop that disease is less. I'm not saying that is negative at all, but it is less than the child that you will that you will give the bottled water. I mean you will use the other milk. I'm not sure what is the word. It flew out of my mind. So you need to breastfeed. Number two, the mother that will have the child, which is a normal delivery, will have the normal delivery, the child will pass through the bacteria in the mother. You know from where she will get the child will get that bacteria. So that bacteria will also help the child later on. So when you have the cesarean section, it is something that some women can prevent it by just walking. Because in the first world, we decide to be in cars and to sit all the time, use a different lifestyle than what we used to use in Africa. So you can prevent that by, I hope you're not communicating with me.
Thank you. Thank you. You were mentioning some of the risk factors, actually, and I think I don't know if I'm having an issue. I think Dr. Chut will also go into some of this a bit later. Can you talk a little bit about the triggers for asthma? Triggers. I was saying, Dr. Sarah, if you can just mention some of the triggers for asthma. You've just talked about the genetic predisposition, the people who come from certain families that have history of allergy or what we call atopy in the family. They tend to also have asthma associated with that. So you talked about the genetic component and also what we refer to as the hygiene theory, in the sense that exposure to bacteria, parasites in early life might prevent you from getting allergy-related diseases. So what I wanted you to give us examples of is what are some of the triggers for asthma, and how do you reduce exposure, and how do doctors find out or diagnose that someone has asthma? Dr. Sarah, you're on mute. So that sort of exposure and diagnosis.
Yeah. Okay. So some of the triggers of the allergy, it can be something that you can find in the environment, or as I say earlier, it can be something within you, which can be the bacteria that is within you that is making you. So if and some because there are different type of the asthma, there is the type that is induced by exercise, like if you are working out or doing something that is more than the normal, then that is exercise induced. There is the type that is induced from outside by, for example, some people can be around the cats, around animals, and because they are allergic to an animal. You can be somebody who was also the smoke, the regular smoke. The regular smoke, like, is not necessarily people who are smoking. It can be like cooking with the firewood. That will be also can be a trigger. And also probably being in an area where the oxygen is low. It can also be a trigger for that one. And in other people, it can be the pollutants that is around the area. The area is not clean enough. And some people, it can be the infection. It can be the infection that is causing this kind of disease. So I'm not sure the next.
Thank you so much for that. Thank you for that. We will, for the time being, as we go to Dr. Chuti, if you can sort out the echo on your background, then we see how, and sort out your mic, then we'll see how we can get back to you to tell us further about what you are speaking about. So Dr. Chuti, I'm going to combine two questions for you because you are representing the children in this discussion. So if you could tell us, I know this is a rhetorical question, but some people actually are unaware. Do children actually suffer from chronic non-communicable diseases, some of the diseases we've mentioned today, and which are those the most common? And if you can give us the statistics for that. And then taking up on from where Dr. Sarah left off, how does a doctor know that a child has asthma, and what are the challenges in diagnosis, especially for children? And how do we manage asthma? So you can build up from where Dr. Sarah left and tell us about diagnosis, especially if it's different in children, and treatment, and what the challenges are, after telling us a little about the statistics of non-communicable diseases in children. Thank you.
Hi, everyone. I'm so privileged to be in this forum today and to be one of the participants. I'm here to advocate for children. Children, they can't advocate for themselves. They can't speak for themselves. So I'm here to speak for them. Non-communicable disease are not they are not uncommon in children. Children are vulnerable like any other age group. A statistic from child non-communicable disease report in 2019, it had reported that 2.1 million children are having non-communicable disease, and 1 million, over 1 million of these children die yearly because as consequences of non-communicable disease. And this non-communicable disease, the key cause for it is reduced physical activity, smoking, as mentioned earlier by Dr. Jane and Dr. Yar, and the fact that 70% of preventable non-communicable disease in adult actually start at adolescent, and they're related to behavior or adapt behaviors during adolescence, like early smoking, alcohol, and all this. So in sub-Saharan Africa, the prevalence of non-communicable disease in children is understudied. But from the global prevalence, 15 million. Yes, hello. 15 million people under age of,
I think Dr. Sarah
of
can
70.
mute. Dr. Sarah, if you can mute your microphone for now. Dr. Chusi, continue. Thank you.
Yeah, as I said, prevalence of non-communicable disease in children in sub-Saharan Africa is understudied. There are no specific data about children, but 15 million of the global prevalence of non-communicable disease are mostly in Africa, which account for 85% of the total death. And non-communicable disease in South Sudan also, I haven't found any data. I haven't come across any data, but there are few data about a study that done in Juba Teaching Hospital for 5,600. They were blood donors. They were screened for hypertension, and the rate was 17.9%. Also in Ministry of Health, South Sudan, they also screened for diabetes, and it was around 7%. So going to the most common causes of non-communicable disease in children, there are so many. Chronic non-communicable disease fall under the chronic disease, but I'll mention just 5 with the statistics globally. We have cardiovascular disease. It accounts for 13.9 million, and death rate of 71,000. Cancer account for 5.9 million. We have chronic respiratory disease, accounts for 108.9. Diabetes is 1.88, and mental disorders 230.3 million. So that's all about the statistics. Going to asthma. Asthma is a disease of airways. It's a chronic inflammatory disease of the airway. Just simply, it could be allergic or it could be genetic. So what happened in children, the onset it's between 6 to 14 years, but it can start earlier than that. Uh, how they present, they normally present with recurrent episodes of wheeze, difficulty in breathing, and also they sometimes can present with severe form like cyanosis and hypoxia. The issue is just very simple. Their chest is their airways are very small, and they are very hyperreactive. Like if they are triggered by anything like allergens like pollen, molds, or dust, or even cold, um, they tend to have a severe inflammation, and their airways are filled with fluids. So when they inhale, it's easy for them, but for them to exhale, it's a problem. um, Sometimes they might just have the symptoms when they are playing, like exercising. So the exercise will induce actually the chronic the inflammatory process. Uh, so this is about the presentation. Let me just go to the diagnosis. Diagnosis of asthma can be diagnosed based on clinical presentation. As I mentioned, symptoms, maybe child coming with first time episode of wheeze or recurrent episodes of wheeze. Um, Sometimes on examination, when you just look at them from far, you see the chest is really hyperinflated. It looks like a barrel, because what happens, they can't remove air from the chest, so they tend to trap the air inside their chest. um, so we can also diagnose there is no a gold standard test, but we can diagnose using a spirometry. A spirometry is a test that is done to evaluate for how can they able to exhale the maximum air from their lungs. So when it's actually below 80% of what expected for the normal low range, that can be diagnostic. We can They can also be diagnosed radiologically using chest X-rays. Um, but there are few challenges with the diagnosis, especially for children who are younger than six years, because first of all, they can't cooperate. Secondly, the procedure is a bit painful for them. So we normally depend on the clinical presentation for the diagnosis. Um, Going to the management, we use short. We use they are relievers or controllers, and they are called short-acting beta agonist drugs. They can be in form of NEPs, or they can be in form of inhaler. It depends on the severity of the disease. Because before initiating the treatment, you need to classify if this child has mild asthma, or if he has moderate severe asthma, or he has severe asthma. So based on that, you will start the treatment. If they are not responding to short acting beta agonist, you can escalate to inhalers, inhalers that contains corticosteroids. And this can be used for a very long time, depending on the control on the symptoms, and if the child improving or not. Sometimes when they present in very severe form of asthma, you can even use IV hydrocortisone, and also they are being treated with long beta agonist, which also play a role in relieving the chest hyperactivity. The aim of the treatment is we need to make these kids grow normal like any other kids, by controlling the symptoms, and we make sure that they are not missing school, and yeah, so it's a lot of work. It's a multidisciplinary approach. It needs parents also to be able to help the kids adhere and yeah, and make and control the symptoms.
Thank you, Dr. Chuti. I think the most challenging thing about children is that, especially the under six, in terms of diagnosis, you have to rely on clinical diagnosis, as you said. And the other thing is that treatment becomes a challenge because the parents have to help the children remain compliant to treatment, and therefore there has to be a lot of involvement of the parents when it comes to managing children who have asthma. Then, okay, thank you so much, Dr. Chifi, for that information. We'll go straight to Dr. Kiden, and we may have to gloss over some questions in the interest of time. So, Dr. Kiden, I will jump your first questions, and you can build up from where Dr. Linda had started talking about diabetes in pregnancy, and what is diabetes in pregnancy? What are the signs and symptoms, and what is the management? And you can also tell us about some preventative measures. Then you can also give us a brief overview about hypertension in pregnancy, and what some of the signs are, and what the management in brief is, and what the preventative measures are. So talk about diabetes in terms of signs and symptoms, the types, and preventative management measures and management, and the same for hypertension. Thank you.
Thank you very much, Anne. And it is indeed a great privilege for us to share in this forum. It is wonderful that we are discussing these non-communicable diseases that apparently, according to the data that has been given, it looks like we have a very high prevalence in our population, more particularly in South Sudan, just as it is in the sub-Saharan Africa. So it is innate in us women that the joy of being a woman is to give birth. But sometimes we face challenges, more especially when we have these non-communicable diseases with us. Apparently, we have got gestational diabetes, which is the form of diabetes that is first diagnosed during pregnancy. However, we have also other things, the communicable diseases like the diabetes that you can have it before you get pregnant. It could be a type 1 diabetes, it could be type 2. But when you have the desire to get pregnant or you find yourself to get pregnant, that diabetes needs to be attended to. So we have globally 16% of the live births are delivered to mothers that have got a form of hyperglycemia in their bodies. And out of this 16% live births, 84% of them are due to gestational diabetes mellitus. So you see the percentage is very high. And in Africa, we have got 9.6% live births due to hyperglycemic states. Unfortunately, in South Sudan, we don't have any data that we can point to that this is our prevalence in the country. So what is it that usually happens in gestational diabetes mellitus? Let me zero there, because the moment you have got diabetes in your system, the diabetes doesn't get better with the pregnancy. Instead, it worsens. So what are the signs? On top of already having the diabetes that we know, you will have hyperglycemia or high blood sugar in your body. You will have things like you will pass urine more frequently, and you will have the tendency to have infections. There is that infection that we have called the candidiasis. It presents with vaginal discharge, which is whitish, itchy, very uncomfortable, right? So when you're pregnant, usually it happens, but with the diabetes in pregnancy, it is worsened. So make sure that when you have those things, you need to have attention needed, right? So the gold standard is that when you go to your ANC clinic, in good places where they are very careful in what they are doing, they will definitely take a random blood sugar for you. And already, if you know that you have high blood sugar or you have diabetes, when you go to the clinic, usually the blood sugars will be found to be high. But if you don't have, and you just go as ordinary ANC or antenatal care, your blood sugars are going to be higher than normal. So how do we answer the question is that how do we then manage this gestational high blood sugar in pregnancy? The most important thing in the management of this condition is that you must go for screening. You have to be screened. If the healthcare thinks that you have a low risk, they will just take a simple random blood sugar. And if you fall under the category of people that we consider to be high risk, like one who has got already a pre-existing diabetes, then you fall under high risk. Or if you have other conditions that may point to us that you may likely suffer from gestational diabetes mellitus, like overweight, we do what is called the oral glucose tolerance test, and that will inform us whether you have diabetes or not. So what is the management? Usually diabetes mellitus in pregnancy it renders you to have a pregnancy that we call high risk. And therefore that means that you need to be regularly attending to your clinic. You have got to make sure that your blood sugars are controlled, and usually exercise or diet is not enough in pregnancy to control your blood sugars. So what we usually do, we supplement it with medicines, and insulin in particular is useful for us. So prevention, you prevent it how? Before you get pregnant, if you know that you have got diabetes mellitus, you are already at a high risk of getting complications of diabetes mellitus in pregnancy. So therefore, before you get pregnant, as part of the management or part of what you're supposed to do, ensure that you do pre-pregnancy tests or counseling. such that the doctor will know whether the diabetes in your body is controlled or not. For some of us who already are obese, before you get pregnancy, because obesity is one of the most important risk factors for development of gestational diabetes mellitus in pregnancy, you have to make sure that you lose weight. Your BMI should be in the recommended levels, such that that pregnancy that you are carrying in your body will bring for you a good outcome. So therefore, one, you have to do pre-pregnancy counseling, such that your blood sugars should be controlled. And secondly, lose weight, right? Studies have already indicated that diabetes mellitus that is controlled has got a better outcome as far as your pregnancy is concerned, and as far as your delivery and the baby that you're going to have in the future. So therefore, it is very, very important that you take note before you get pregnant. Make sure that you have controlled your diabetes, right? Now going on, preeclampsia or high blood pressure in pregnancy, we have got, this is a cardiovascular disease that affects your blood vessels, it affects your heart, it can affect your kidneys, affect your liver, your brain, and so for that matter, we call it a multisystemic disorder in pregnancy. If you happen to get pregnant when you have got hypertension, then we put you under a class just for us to know how to manage you well. We say that you have pre-existing hypertension or chronic hypertension, all right? So you may sail through the pregnancy when you have not developed the other conditions that have affected your target organs, and you deliver. But meanwhile, as you go through the pregnancy, we know that you have to control your blood pressure. However, there are some of us that can have the high blood pressure, and when you get pregnant, you develop end organ or target organ complications. So we call that how do we call it? Superimposed chronic hypertension with superimposed preeclampsia. So there are those categories like that. And then we have also what we call the climax of it, if I can say it, preeclampsia, which is characterized by convulsions. And the most important thing that we have to get to know is that when you have high blood pressure in the pregnancy, this high blood pressure can be set in beginning from 20 weeks of pregnancy, halfway the pregnancy. So that is early onset preeclampsia, and then we have the late onset that sets in from 34 weeks and above, and it past even the time of delivery to 6 weeks after you have delivered. So how do you know that you have high blood pressure in pregnancy? Supposing you're in the house, you have no idea. As it is, most of our women do not want to go for ANC very early. How do you know that now I have, how do I feel within my body? That should inform me that things are not good. One, headaches, right? Two, you will get, your eyes may not be able to see well. You see cloud, you will see something like cloud. Things are not clear. Your eyes, your eyesight is not correct. The other thing is you can begin to feel abdominal pain, more especially in the upper part of the abdomen, particularly on the right side. You will feel some pain there. And then, of course, when you go to the hospital, they will take your blood pressure, and it will be, if it is more than 140 out of 90, and sometimes it can present with some proteins that is been seen in your urine. But we have also seen cases where there is high blood pressure, but there is no proteins in the urine, but there is evidence that there is end organ damage. So we do quite a number of investigations for you, and we can come to the conclusion that you have high blood pressure if some criteria is met. So the moment you have headache, you have got what we call epigastric pain. You have blurring of vision. Your blood pressures are high, or sometimes you can swell, the body can swell and become filled with water when you press your legs or your hands. Sometimes your face is swollen. You may not have the headache, or you may not have the epigastric pain, but make sure that when you begin to see your body is abnormally swollen, then you have to go to the hospital and be checked. The other important thing is that in the management, when you have high blood pressure, before pregnancy, there are some particular medicines that you are given and which may not be very good for your baby. When the blood pressure is detected, we take you off those medicines and we give you others that are safe in pregnancy. So it is important that you have the habit of going into a MC clinic early enough, such that this high blood pressure can be picked up. Sometimes it can be inside your body, and it is not giving you some signs at all or some symptoms at all. Then, as you are laboring or you're in the house, the only thing that alerts people is you falling down and you behave like as if you have epilepsy, you're convulsing, or loss of consciousness all of a sudden. So blood pressure can behave anyhow in pregnancy. So that will make me overemphasize, or even I cannot emphasize it enough, that antenatal care for every pregnant woman is very, 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 very important. Because sometimes in the clinic, the majority of the people, we see them developing the hypertension. We see them progressing. So it is important that you go there. I don't know how I can encourage you or how I can convince you that the moment you are pregnant, whether you have pre-existing hypertension, diabetes, whatever it is, that please make sure that you go to the clinic. Hypertension is one of the major causes of maternal mortality worldwide. It does not spare when it comes. It does not spare the mother. It does not spare the baby. And the whole thing is very confusing if you're not very careful. So please make sure that you go there and check.
Maybe
So,
Dr. Jane can mention a few of the consequences of hypertension and diabetes in pregnancy on the mother and the child. Then I'll give you 2 minutes to do that. And then we can go back to Dr. Jane. Thank you. The consequences.
The consequences, what we love calling complications. So diabetes and hypertension in pregnancy, they love, they are brothers and sisters, they love themselves. So usually the complications that develop from these two conditions are relatively similar to the mothers with preeclampsia or high blood pressure in pregnancy. They have got the tendency to have a preterm delivery. There is a high likelihood that you deliver by cesarean section. The tendency for you to develop complications such as kidney failure, liver failure, strokes, and blood clots in your body. So those are some of them to the mother. And then to the baby, high blood pressures will always cause you to be delivered prematurely. And that means that your survival outside, the survival of the baby, is very, very hard. All right. Then they have a tendency not to grow well because high blood pressure is the disease of the blood vessels. Blood transportation from the mother to the baby becomes difficult. Hence, the baby does not grow well. The baby, usually there is what we call the placenta abruption. Placenta can separate from the baby before from the mother before the baby is born, and that can predispose to intrauterine fetal death. For diabetes, and to the mother, we have the tendency for abortions. We have got also preterm delivery, predisposition to infections, and then an increased risk of developing high blood pressure in pregnancy. I told you that these guys love themselves. And then it can cause also maternal distress. It can blind you, you can become blind. And onto the baby, we have got the tendency for the baby to grow excessively big inside, and what is called the microsomia, and that will cause a difficulty in the delivery of the baby. Therefore, the tendency to be done cesarean section is high. And then the baby also have got major complications with hormonal controls, and that will become very difficult for the baby to cope up from outside. The baby has got a tendency to develop difficulty in breathing after being born. Even when that baby is big, it is not fit, it does not cope up easily with the outside like any other baby. Then lastly, these babies have got the tendency to die inside the womb. A mother can be carrying the pregnancy and the baby dies. All of a sudden, nobody can explain. When you take the blood sugar, it is very high, right? So those are some of the complications that we get. But importantly, my sisters, please make sure that before you get pregnant, let your high blood pressure, let your blood sugar, whatever chronic illness that you have, make sure that it is under control, and then make sure that you go to the clinic regularly and make sure that you deliver safely. Thank you.
Thank you so much, Dr. Very comprehensive. Dr. Jane, I think Dr. Kiden has mentioned some of the danger signs that you are going to tell us. You can emphasize a little bit about some of the danger signs that people with hypertension can watch out for and advise them on what to do. And also tell us a bit about the long-term consequences of uncontrolled hypertension and why follow-up is important, and give those who are affected some advice on that. So danger signs, just a few, because Dr. Kiden mentioned most of them, and the long-term consequences, and follow-up, the importance of follow-up. Thank you. So 4 minutes, thank you, in the interest of time.
Well, as I mentioned earlier, primary hypertension, which is essential hypertension or idiopathic hypertension, because we don't know the cause, accounts for 90% of blood pressure. We say it is a silent killer because a lot of people do not know that they have high blood pressure until it is found either accidentally or they show up to the hospital or the clinic with target organ damage. Target organ damage, as I said, is when there is another organ affected plus the blood pressure. Either they have chest pain, they have headache, they have blurry visions, their kidneys are failing, they have swelling in their legs. Those are all target organ damages. So secondary hypertension accounts for about 10% or 9%, and basically it is from renal artery stenosis. Diagnosis of hypertension is by checking your blood pressure more frequently than usual and assessing the target organ damage. And for diagnosis of secondary hypertension, we usually do an ultrasound on your renal to make sure that it's not only atherosclerosis, there's no renal stenosis. The artery is not having stenosis, because that changes how your blood pressure is managed. Other complications, which include maternal complications, have been mentioned, so I'm not going to mention that. But the medications that we give for blood pressure differ. We have several groups of medication. We have beta blockers, ACE inhibitors, we have thiazides groups, we have ARBs, we have calcium channel blockers, and we have antiarrhythmics that we give to the patients, even the groups of the adrenogenic beta and alpha blood pressure medications. We give those depending on what really is your blood pressure and what are your other comorbidities. Now, given that we are Sudanese, we fall in the United States under the African Americans, and back home we fall under the Africans in general. There are certain types of blood pressure medication that really works for us best, and some do not. We also look at those screening the person. So we say, according to JNC7, JNC8, the thiazide drugs are best for the African Americans, and especially somebody who comes with a target organ damage of edema on the legs, on the ankles. You will want to give that person a thiazide drug so that they can pee out that swelling, allows them to breathe, reduces pulmonary edema and every other thing, which is a complication, a target organ damage complication. But if the person tells you that I'm a construction worker, I work on the road outside, I don't have a place to pee, are you going to be able to give that person that medicine? So there is a lot of assessment that goes in there. So basically, if you come, for example, you have a target organ damage of CHF, congestive heart failure, because your blood pressure was not controlled for a long time, and your heart has fallen apart because it is tired of pumping against resistance all the time and has fallen apart. Now you have to be given probably a beta blocker and another medicine, depending on how your heart muscle thickness is, how your heart muscle is still capable of working. So your blood pressure medication will differ from the person who just have essential blood pressure, which is a chronic problem, but now you have a target organ damage. And there are other medications that we give specifically to patients who have blood pressure or have diabetes. So for example, ACE inhibitors is given to prevent target organ damage in patients who have diabetes. They do not have to have high blood pressure. As long as they have diabetes, we give ACE inhibitors, for example, the prils. A lot of them end with pril, but if you can say lisinopril, captopril, any one of them, to prevent target organ damage, which is the kidney damage from diabetes, because that's the end game of it. We have a lot of Africans here in the United States and back home that are ending up in kidney damage, and they require renal transplant. Sometimes they can't even get a kidney. They have to die out of kidney failure because they did not know that they had blood pressure for a long time. So that's also another complication of high blood pressure. So in a nutshell, consequences of not controlling your blood pressure or not getting diagnosed early or checked up for blood pressure leads you to not only congestive heart failure, not only kidney failures, you can have a stroke, you can, which is a CVA, you can lose your kidney entirely, you can become blind, you can have many, many, many other complications that are preventable. How do we prevent this? We can prevent and control all the modifiable risk factors that lead us to uncontrolled hypertension. There are two factors. There are non-modifiable risk factors and modifiable risk factors. The non-modifiable risk factors include your sex, your ethnicity, your genetic factor. So for example, I'm a female. and I'm in my 50s, and I am an African American. Those are non-modifiable risk factors because you cannot change your age, you cannot change who you are, you cannot change your DNA. But they are modifiable risk factors that you can use to modify that. Activity is very important. Sedentary life system is not helping us. Your diet, low cholesterol, low carbs, is very, very important. It helps the blood vessels remain normal and help your blood flow well. Smoking, reducing stress. I cannot emphasize this enough. Alcohol. When I say activity, I realize I didn't define activity. Activity is defined as a mild to moderate activity between 30 to 60 minutes, 5 days a week. People will say, oh, I am working, I'm going to work, I'm doing this. No, you need to have moderate activity, which is 30 to 60 minutes, 5 times a week. That is called activity that can help with your cardiovascular system. What is the low cholesterol? What is the low carbs? What is the low salt? Make sure that you do not add any additional salt. Have salt in moderation. There are some foods, you may not even need to add additional salt to it. So those are examples of low salt. Low cholesterol, Z-alketir. The foods that are cooked with a lot of oil are a predisposing factor for us to collect cholesterol in the veins. And if there is cholesterol sitting in the veins and the arteries, they are not going to be easily allowing blood to flow through. When they become calcified, blood cannot flow through easily. That's building up a problem in our blood vessels, and that creates stagnant organ damage. You can just have an MI, you can have a heart attack, you can have a stroke, and this can lead to death. Taking aspirin after the age of 50 is a good idea if your activity level is compromised due to some situations. For example, if you had a car accident and you have chronic back pain, you're in a wheelchair, you cannot do some rigorous activity, you need to take an aspirin. Or your provider or your family doctor will also evaluate your aspirin regimen if it is a good thing for you to take. Either you take aspirin and deal with the side effects. That can be GI bleed if you have other side effects or other complications, or you don't take aspirin and you can get a stroke that can kill you. So those are some consequences. I realize I didn't also discuss about low carbs. Low carbs is really from what we call our grains or starch. Eating this in moderation really allows us to control ourselves, our blood pressure, as well as our diabetes and obesity overall, because obesity is really a big factor. So 18 grams of anything that is grain is allowed per each meal. Increasing vegetables and fruits on your diet will allow you to have a balanced diet. Yenta kan gakul ish, for example, the sliced sandwich bread. If you have 2 slices, you have enough for that meal. You cannot have more than that. Lakini yani zai zamani ndana ish beledi da wala ish bita Sudan da ashan koish tabi gargas wahid tabi gargas itnin, and then tabjakul talata bimula. That is over your calories that is required for the day. A normal adult is required between 1,800 to 2,020 calories per day. And you don't have to consume that much if your activity is not in moderation. So in a nutshell, therapeutic lifestyle modification is what that can allow us prevent and modify the modifiable risk factors to control our blood pressure. We have some people control their blood pressure by diet. And they don't drink, they don't smoke. They reduce their stress by doing yoga, by doing exercise, by meditating, and doing other things. Even a massage can help reduce your stress level. And chronic stress can build up into a problem that you don't need. So in a nutshell, let's work on therapeutic lifestyle disease management. Let us work on our diet. What we put inside in our body is what can make us bad. It can make us good if we use in moderation. It can make us sick if we use in bad things. Lastly, about the data, I want to talk to people who are working around Juba. If you have a clinic, you can start collecting data. If you work in the hospital, you can start collecting data. How are you going to start collecting data? If you see 10 people in a day, how many of them did you diagnose with blood pressure? In a month, how many people did you see? How many of them were women and how many of them were men? And how many of them had high blood pressure? How many of them had diabetes? That is the starting point for collection of data. Nobody's going to come from somewhere else and help us. South Sudanese said, here is a system we're going to design to collect data. That's the easiest way that you can start collecting data and making decisions about the population you care about, the population you take care about. And then let us also encourage the system in Juba and carry out awareness that we need to let our population know that having a family doctor is important. Getting an annual checkup every year, getting a physical examination is important. Because obesity is now increasing, and inactivity is increasing, years old, there is and business and everything. We have that level of sedentary life. We need to start encouraging people that every year they need to be screened for cholesterol and they need to be screened for diabetes. How do you screen for diabetes? Get a hemoglobin A1C. Instead of having a blood glucose tolerant test, which is 3 sets of exam, just get a hemoglobin A1C once a year, screen for cholesterol, and you're good to go.
Thank you, Dr. Jane. I think you've emphasized the importance of statistic collection in order to make policies or change strategies in terms of control of these diseases. So building up on that, I think Dr. Linda can talk to us a little bit about diagnoses of diabetes, not too much in detail because Dr. Kiden had mentioned a few things, and management of diabetes and why follow-up is important and some of the consequences that we do see in people who have uncontrolled diabetes. And for the acute cases, what are the danger signs to look out for? So diagnosis in brief, management, the importance of follow-up and some of the consequences and danger signs that should be watched out for. Dr. Linda, 5 minutes. Thank you.
Oh. Okay, thank you, Dr. Ann. To diagnosis of diabetes, so anyone who has symptom of diabetes or the one who is at risk should go for the test. The test usually we use it is a fasting blood sugar test and random blood sugar test, glucose tolerant test, and also we can check the urine for the protein and the glucose. How we treat it? We have 3 methods to treat the diabetes. We have diet alone. 60% of diabetes patients can be treated by diet alone. So the diet should be balanced. For example, we should take balanced diet of carbohydrate, fats, and protein. So the food that we should avoid it when we have diabetes, we should avoid food like sucrose, glucose, and food that contain high glucose and sucrose. The second method is diet and insulin. Insulin is indicated in all patients with type 1 diabetes, or also the patient with type 2 when the hyperglycemic is not controlling by the diet combining with the oral hypoglycemic drugs. The third method is diet and oral hypoglycemic drugs. And this one is indicated only in type 2 who fail to respond to the diet therapy. The oral hypoglycemic is not a recommendation for the gestational diabetes. So it's not good for the pregnancy woman with diabetes. The other aspect which is important for the follow-up is education of the patient. It's very important for us, a doctor, to educate the patient how to use the glucometer to check the blood sugar at home. And also we should teach the patient for how to detect the ketone body in the urine by using the simple urine strips. And also we have to teach the patient how to know and differentiate between the symptom and complication of the diabetes, so that the patient cannot go for the hypoglycemic, and this the most dangerous symptom of the complication of the diabetes. So in case the patient develops the symptom of the hypoglycemic, like sweating, hunger, confusion, drowsiness, so what he should do? So usually we advise the patient to drink oral glucose, like mix sugar with water and take it. Or we usually advise the patient to take with him a sweet. So in case he feels this symptom, he can take the sweet and it can help him to prevent the chronic complication of hypoglycemic. So those patients, the complication of diabetes, the patient is uncontrolling diabetes. Usually they can go to the complication like hypoglycemia, and these are the most dangerous complication, diabetic ketoacidosis, and the chronic complication like heart disease, nephropathy, neuropathy, retinopathy, like impairment of the vision, renal failure, loss of sensation, weaknesses, and damage to the foot. And the patient can come with infection like fungal infection of the skin, bacterial infection of the skin. So, and also dementia, and patient can enter to depression, and this one can lead to the death of the patient. So, uncontrolling diabetes in pregnancy mother, as Dr. Kiden, she mentioned before, the mother, it's complication to the both mother and the child. So it is include premature birth, high risk for type 2 diabetes later on for the both mother and the child.
Thank you, Dr. Linda, for that comprehensive overview. I think before we go to Dr. Sarah to tell us a bit more about the management of asthma, Dr. Chuti, you can follow up on what Dr. Linda has talked a little bit about. When it comes to diabetes in children, is it common? Do they have a different type from the ones for adults? How is the treatment? Is the treatment different for children? And what are some of the challenges, especially for treatment in children, and some of the long-term consequences? And if you have any advice for parents, you can give us at this stage. So diabetes in children, what is the management? What are the challenges in treatment? What are the long-term consequences, and what advice would you give to parents? Thank you. Sorry, Dr. Chuti, unmute. If you could please unmute yourself, and let's limit our answers to 4 to 5 minutes max in the interest of time. Dr. Chuti, thank you.
Diabetes is common in children. The most common type is type 1, which is insulin-dependent diabetes. They also develop type 2 diabetes, but it's related to risk like obesity, and they develop that earlier on. As it mentioned earlier, diabetes type 1 is insulin deficient, whereby the child pancreas cannot produce enough insulin to uptake the glucose to the body, the tissues, because this glucose is used as energy for many mechanisms in the tissues. So when there is an absolute deficiency of this insulin, the sugars build up in the blood, which is called hyperglycemia. this hyperglycemia, it's the glucose has the tendency to pull the water from the cells. So the glucose is followed by water. So that's why we see presentations, symptoms. They present with polyuria. They urinate a lot because as the glucose excreted, it followed by the water. They also have dysphagia because their appetite center is somehow suppressed. You know, the brain depends on the glucose as the main source of energy. And they also present with, they also have loss of weight because when the body can't get glucose as a source of energy, the body tend to break down fats, to break down proteins as a source of, as alternative source of glucose. So they will be wasted because they will lose the fats. Yeah, so these are one of the most of the symptoms that the children present with. Another thing, diabetes. Diabetes in children, it somehow is stressful in term of management, because the only treatment is insulin. They can't produce their own insulin, so they have to get exogenous insulin from outside, and they tend to prick themselves at the upper arms, the abdomen, the thighs. Yeah, and it becomes a routine. It becomes a routine thing that they do, so it put them in a lot of stress. Dr. Linda mentioned that there are many tools to diagnose diabetes. I'm not going to talk in details. There is fast random blood sugar testing. There is OGT, which is oral glucose tolerance test. So the fast random sugar testing become positive when the random blood sugar is more than 11 millimole per liter per kg per liter, or it's more than 200 millimoles per liter. That's diagnostic. The OGT, they are given 75 milligram of sugar, and they test the blood after 2 hours. If it's still the same value, it's more than 11.1 milligram per deciliter, it's also diagnostic. So how do we manage diabetes in children? As I said earlier, the only treatment is insulin. The insulins, there are many types. There's short-acting insulin, long-acting insulin. There are bolus insulin that are given pre-meals. I'm not going into details of this, but before you start managing these children with insulin, they need diabetic education. Diabetic education, mostly the caregivers are the ones getting the education. They are told about what is the disease, how is it caused, how to actually administer the insulin, how to prevent complications, because you might treat the hyperglycemia, but you end up with hypoglycemia. So Dr. Linda mentioned when they have hypoglycemia, they should know the symptoms, so that they can rescue themselves, because it can be life-threatening, and it is one of the emergencies in diabetes. I forgot to mention about okay, let me just go to complications, because I think most of the things were mentioned. Complication.
Can give us complications in about a minute? Thank you.
Yes.
1 minute for complications. 1 minute.
1 minute for complications. Okay. Complications. The most serious one is diabetic ketoacidosis, and this is the first presentation. Many of the children who are undiagnosed, they come with diabetic ketoacidosis. Diabetic ketoacidosis, they come in coma, they have high level of hyperglycemia. It's life-threatening. They can even lose their life if they are not rescued and if they are not brought on time. The other consequences, which are long-term, diabetic retinopathy. It's cause of blindness in children. It accounts for 30%. We have diabetic nephropathy. The diabetes has effect on the kidneys. The cause is unknown, but with long-term diabetic nephropathy, they might even develop hypertension. And when they develop hypertension, actually there is a damage to the kidneys. When there is damage to the kidneys, the toxins that are released by the kidneys will accumulate in the body, and it actually affect the brain, what we call the uremic encephalopathy. They also tend to have diabetic neuropathy when the nerves are affected by the hyperglycemia. They damage the axons. But it's not really common in children. We mostly see it in adult. So my
Thank you.
advice to the parents.
Yes, please give the advice for the parents as we move on now to Dr. Sarah. The advice to the parents.
Yeah, the advice to the parents that children with diabetes, they need to be treated like any other children. We need to make sure that their food is balanced in terms of getting enough carbohydrates. Should be 50 to 55% calories. Getting lipid, 30 to 35%. Also proteins, and it should be adequate because these children are growing and they need all this substance to help them grow optimally. The other thing, we need to encourage exercise, because there are some studies that has shown that exercise actually increase the number of the receptors, the insulin receptors. So it helps this insulin actually getting into the cells and help uptake the glucose from the blood. They need to take care of how these children administer insulin. There are many ways this insulin can be administered with syringes. There is some drops which are used to inject actually the insulin syringes. So they need to make sure these children are not injecting themselves in the same sites, in the same area every time, because this will cause something. It will cause what we call hypertrophy on the muscles, which lead to a swelling of these muscles, and it will reduce the absorption of insulin. Like if every time they inject it, they're not getting enough, so they will underdose, and when they're underdose, they end up with sugars which are not controlled.
Okay. Thank you, Dr. Chichi. So basically what you're saying is that lifestyle measures in terms of control of diet and exercise, then diabetic education in view of that, and also in terms of using the medication and the injection, right? And because parents are so important in the management of diseases in children, especially chronic diseases, then they should be very involved in the care and also get the diabetic education. So what you will let us know later when we're doing our final round of recommendations, you'll be able to tell us some of the challenges that especially pediatricians have when it comes to management of chronic diseases in children. So we will go over to Dr. Sarah. Dr. Sarah, in the interest of time, I will give you 3 minutes to talk in summary about the treatment for asthma and why compliance is an issue and some of the consequences of uncontrolled asthma. Just 3 minutes, and then we do a final round of challenges and recommendations, starting with Dr. Jane. So Dr. Sarah, 3 minutes, and then we go to Dr. Jane, and then Linda, and then Kidin, and then Chuchi, and then finally you to give us challenges and recommendations so that we can wind up the discussion. Dr. Sarah, 3 minutes. Treatment of asthma, why compliance is an issue, and what are some of the consequences of lack of compliance.
Can somebody mute over there? What do you, can you hear me?
Yes, we can hear you, Dr. Sarah. So I'm saying if you can talk about asthma treatment in summary and the reasons for non-compliance and what are some of the consequences of non-compliance or lack of control when it comes to asthma. 3 minutes only so that we can go to our challenges and recommendations. Thank you.
Sure, thank you. Okay, so as I've given a short time, so I'll just try quickly. So the control here, I'll start with the compliant. The compliant is, of course, with the myths. People are afraid, they are ashamed to use it in public, and because they don't want other people to see them that they are using. And sometimes also the mothers, probably I'm not blaming them, but it can be we are too busy. As we know, our African busy life as mothers and as women, we are too busy to check with the children whether they took the medication. So we need to actually be there to make sure that they are using the medication. Also, the forgetfulness. If the child is going to school, for example, and they may have forgotten the inhaler at home, so that's one of the reasons of the non-compliance. With the treatment, it will start with us, the mothers. The way it will start with us, the mothers, if we make sure that we know the symptom of our children when they are happening. We know that with the asthma that can happen at night, make sure that somebody that is sleeping next to the child that have the asthma that happen at night, because there is that type of asthma. So be sure that is there so that the treatment start there with the mother, and then we'll go to the doctor. So again, with the mother, you will make sure that you explain to the doctors and you tell them the history of life. They will know where is it coming from. So now the treatment will be divided into the one that will rescue your child at the time of emergency, and there is the treatment that will keep them, away from the emergent situation or the flare of asthma, which is when the asthma really become worse. So the first treatment, which is the inhaler, and this is the type that the child will carry around with them. But again, it will go back to the mother, because if you know how many times a day your child will get that flare or will be in that type of stress using the inhaler, then the doctor will decide whether that inhaler is enough, or is the doctor supposed to move to something more stronger and something more than that. Then we come to the other type of medication. The other type of the medication, they are the medication that will actually remove the inflammation. And the other type is the type that will, remember when I told you that it is the narrowing of the airways. So the airways will need to be opened by other medication. So the medication that are opening the airway. And there is the SABA and the LABA, just to make them easy for you. And then the LABA is the long acting, which is for the people that have a really severe type. And the SABA is the one for the one with the short acting. This is the one that is intermediate type. So again, knowing the how many time your child, but again, I will advise the mother that you will know how many child, what is happening with your child by simply placing your hand on the chest of your child, because the chest of your child will tell not the severe one, but will tell the beginning one, because you can feel that the breathing is not, because the breathing we shouldn't be hearing, we shouldn't be hearing how we breathing. We shouldn't be feeling our chest when we breathe. So with that one, you will know, and make sure that you follow your child with this simple tactic. And again, the medication that you use as an inhaler in the first world now is being used with another pipe that is being put with it, instead of the way we used to see it, that is being just used directly, because they found out that it will kind of affect in the area of the mouth. So it will give you another different problem, which is it will give you some kind of a fungus that will grow in the mouth. So make sure that, because I know in our country, sometimes we will just go and buy the medicine without the doctor. So it's better that you follow up with the doctor instead of just buying it and using it. And when you use it also, it doesn't mean that you use the medication and you stay away from the doctor. Make sure that you use the medication and follow up with the appointment. Be there at the appointment so that the doctor will see two things: whether the medication is working, or whether that there is a side effect from the medication, because this medication, the other two, they have a side effect that can affect your child. But the other thing that I will add to this one, that your child, okay, your child is just normal as the other children. If it is the asthma, it's just as normal. It's just at that time of the emergency that things are different. So the child is just as the other children, unless if it is bronchitis or the other things that are happening. So I hope I did my time right.
Thank you so much, Dr. Sarah. It seems we have representation for children, two representatives, Dr. Chuti and Dr. Sarah. So thank you so much for emphasizing what the parents should do for their children, especially when it comes to asthma, because the adults, since they make the decisions for themselves, it's easier for them to manage. But for the children, the parents have to actually look into it and make sure that they take their medications as appropriate. So now we will go to the final round of our statements. So now we can talk, we can just give a brief overview of some of the challenges in the specific diseases that we've talked about in terms of treatment, whether they're individual, clinician related, or Ministry of Health related, and then you can give recommendations. So I will give each panelist 2 minutes only, please, in the interest of time, to talk about challenges and recommendations. And we will start with Dr. Jane. And then after Dr. Jane, we will go to Dr. Linda. After Dr. Linda, Dr. Chuti. After Dr. Chuti, Dr. Sarah. Then we will end with Dr. Kidin. So Dr. Jane, 2 minutes. 2 minutes. Thank you.
Okay, I choose to use my 2 minutes for to address few things. Number one, compliance with high blood pressure medication has been documented very poorly in Africa and especially in Sudan. In the very well city of Khartoum, compliance has been documented to be 59%. And in Kassala, about 29%. We have no data for South Sudan. So we don't know what the compliance is. But I'm here to tell everybody that if you are in any chronic medication, such as high blood pressure, diabetes, you're taking it for life unless you have succeeded with therapeutic lifestyle modification, weight loss, and your doctor decides to taper you and remove you or reduce your medication. Otherwise, you're taking it lifelong. Do not stop it, because you can get a heart attack, you can get a stroke, you can die. And then those who have diabetes and they don't have high blood pressure, they will be added ACE inhibitors to prevent kidney damage. So when you have that, Do not stop taking it just because I don't have high blood pressure. Why am I taking this medication? It's usually a small dose, and you can take it as long as your kidneys are still okay. When you have a problem with your kidney, that's the first medication the doctor will take away. So think about that. And then also with the complication of diabetes, that there is a lot of amputations happening in different countries. We need to know that with diabetic neuropathy, which is burning and tingling and numbness of the legs that happen. When those are happening, you have uncontrolled diabetes and you need to get it under control. Also, I'm kind of summarizing this from everybody's discussion, especially in asthmatic children. Given the literacy and education in South Sudan, I feel that the father has to be included into the plan of care, because if we talk about the mother alone, we're burning the woman. She is the breadwinner. She is taking care of the rest of the kids she's doing. And a lot of times the men are the one who went to school and this woman did not go to school. We need to include the father into the care plan. Otherwise, we're burning out this woman. She will fall apart. And if she forgets, this child is not getting treatment. And if this child dies, we're blaming the mother. We need to add the father to the care plan. Centralized care plan increases compliance. Lastly, COVID-19. All these chronic diseases that we talked about, if they are not under control, they are a risk factor and they are likely to increase our problems with COVID-19 and even project death. Because if you have asthma or COPD and it's not controlled, that is a respiratory problem. And if you have COVID-19, coronavirus, which is also a respiratory problem, it can exacerbate your issue. Your lungs can collapse because with COVID-19, you can have fluids filling in your lungs. And with that fluid fillings in your lungs, you cannot breathe. That becomes a problem. You can have blood clots. And we know if you have high blood pressure, your veins are not working okay because they are not controlled, you have a predisposing factor. If you have diabetes and it's not controlled, your blood sugar is out of place. What does that do to coronavirus? When you have fluids filling in your lung, it is out of place. That's why you hear people in the ICU, we need ventilators, we need that. But actually, when you get on the ventilator, your likelihood of getting out of the ventilator or surviving in a third world country is probably 1%. So we need to be very, very careful of controlling our chronic diseases. And again, with COVID-19, we have been learning through this pandemic. It's now almost 8 months. We are in it or going to 9 months in it. We have learned that preventing these chronic diseases, having them under control and staying at home, washing hands, wearing masks, and really being away from people about 6 feet or more helps us prevent this disease. If we can, things are difficult in other parts of the world. Some places are even facing more different challenges than we do. Let us try to use social distances. If you are sick, stay away, isolate yourself from other people. In that way, we do not transmit the diseases. I may get the coronavirus and be okay with it, but somebody who has uncontrolled chronic diseases gets it and they will die. Therefore, we need to be ethical in our approach. We need to be moral in our thoughts that we do not have transmit these diseases to other people. Wash your hands, wash your hands, wash your hands. Cover your mouth, mask up, so that we can be alive. And I think that's it. Thank you very much. And everybody was
thank you so much.
I appreciate it. Bye-bye.
Thank you, and thank you for mentioning COVID-19 and the risk it brings for people who have the chronic diseases, and how the rest of us should be able to protect them by practicing social distancing and respiratory hygiene. Dr. Linda, 2 minutes, challenges and recommendations.
Okay, thank you. I forget to mention the importance of the follow-up. Follow-up is very important for the early detection of the symptom of the complication and treat it early. So the big challenge that we are doctor or the medical personnel are facing in South Sudan is the early detection and management of the diabetes patient. Because we don't have a specific center, or we don't have an active center that is active for the diabetes, so that no one is coming for the screening. We just detect it as emergency, and or when the patient come for the normal checkup, and then we detect the patient that has diabetes. And also finding the right medication regime for the patient. Because most of the diabetes medication are not available in South Sudan. So we are facing a big challenge of getting the right medication for the patient, especially the insulin. It's not easy to get it in South Sudan, and it is very expensive. My recommendation going to the individual like that. So anyone who is at high risk should go for the screening. And the one who has diagnosed with the diabetes must develop the self-management skill and commit it to make lifestyle change. The one goes for the physician and the other, my colleagues, let us focus on education the patient. Let us find the right medication regime for this patient. And also let us teach the patient how to prevent the complication. And for our Minister of Health, they have to improve the center by providing the adequate facility to help early screening. And also they have to provide diabetes prevention program for our staff, medical staff, especially nurse also, because they are playing a very big role in the prevention of the diabetes. And they should provide a fundraising to facilitate more training in our medical field. And also they have to provide diabetes medication, and they have to focus on the lowering cost of the medication in the South Sudan. Thank you.
Thank you, Dr. Linda, for that comprehensive list of recommendations. Dr. Chuti, challenges and recommendations.
Okay.
2 minutes.
We face many challenges in managing and monitoring patients with chronic illnesses. One of the challenges is after these patients have been diagnosed, managed in the hospital, and they're discharged home, they are lost to follow up. They are lost to follow up for many, maybe risk factors that we are not aware of. And this is an area that emphasizes factors. The other thing, we get patients with chronic illnesses coming late, and there is nothing much you can do. You know that they have bad prognosis, and we really wish if you get them earlier. So I have also emphasis on looking for these patients in the community and screening, knowing their problems earlier, so that we can actually help them. My recommendations goes to the stakeholders, the governance, concerning making more effort to prevent non-communicable disease, because we don't have the capacity to manage non-communicable disease later on because of logistic and many of these patients with non-communicable disease, they are misdiagnosed. Sometimes they are underdiagnosed, especially now in South Sudan. I'm not sure if we really able to diagnose patients with cardiovascular issues, because we don't have echoes. Patients with cancers, it's a big challenge. So they need to put more effort making studies, so to allow for better interventions. I just have a concern about diabetic adolescents. People need to really take care of this category, because they have many issues. You know, the adolescent itself, it's a phase whereby they are confused, they have behavioral issues, so they tend not to get the medications. They would actually lie about that they have taken the medication, or they inject themselves. So when you look at the diabetic diary, it looks like the sugars are controlled and all this, but it's something that they manipulate with it. And they are the most category that come in DKA, and they are more prone to death because of that. Yeah, that's what I can say for now. Thanks.
Thank you, Dr. Chupi. Thank you so much for encouraging screening and even community screening, not just waiting for the patients to go to the hospital. And speaking about adolescents who actually are difficult to manage because they are at a transition where they're trying to understand why they have this chronic disease, while their peers don't have to struggle with the long-term medication and long-term and consequences of the diseases that they suffer from. So thank you for speaking up for the adolescents and for emphasizing that they need to be followed up much, much more strictly because of the issues that come with getting into adolescence. Dr. Sarah, 2 minutes, challenges and recommendations. Thank you.
I'll go first with the recommendation. The recommendation is if your child is asthmatic, asthma, if it is, especially if it is the one that is because of an allergy, you need to know that allergies come with other allergies together. So make sure that you pay attention to what your child is eating, because the child may be allergic to some kind of a food also. And also pay attention to medication that you give your children, even if they have other sickness, and that you know that the people just buy them over the counter and use them. Especially stay away from aspirin, because aspirin can also induce asthma by itself. Even if some children that don't have, but you have it in the family, that can induce the asthma. And also defending the parents to defend their children from any infection. Any infection is teach them how to wash their hand, like it was said earlier. Teach them how to when other people are coughing around them, to back up a little bit, because and also to teach to ask the teachers to teach the children when they are coughing, especially among the child that is asthmatic, to make sure that they cover their mouths when they are doing that. So that will be defending your child. Even if you have to educate the people around you by defending your child, I don't think it's something bad with that. Also, the nutrition. So the nutrition will go with the other one. And then also stay physically active, but not the activity that will probably make kind of exacerbate your child's situation, or maybe that will lead to flare. So maybe start with a simple short exercise that you can do with your child, and then see where your child stand on those exercises, and then you can increase them slowly. And also tend to the emotional need of your children, because stress can be one of the factor. It doesn't have to be a stress of running or doing something else. It can be a stress from within that will be. And also for those who are smoking, try to stay away from your children, or try to stay away from around the kids. No matter whether they are asthmatic or not asthmatic, try to stay away from them, because you can be a smoker that just triggering the asthma that was not yet on that child. So you can be the one that is actually starting the asthma on some of the children that the asthma did not come up yet, because there has to be an outside trigger. They can have it genetically, but you have to have something from the environment. And also for us as parents, and I'm saying parents because I was saying earlier mother, so I'm saying parents. So here, and thank you, Dr. Jane, for saying that. So I'm going to say parent. So here, is that me who is making the noise, or somebody? It's unmuted. Somebody's unmuted.
That is Dr. Chuti, if you could please mute. Yes, thank you. Thank you,
Mm.
Dr. Sarah. If you could give us your recommendations, if you can hear me, your recommendations, then we go to Dr. Kidin.
Okay, so my recommendation is to our community, whether it's here or whether it's in Africa, and especially in Africa. So if you are somebody who have asthma, please make it your responsibility to teach others, because if you make it to the age that you became older, make it to teach others that this disease is not a taboo, or it's not something that is really something that is bad, or something that is a child responsible for it. Make it your responsibility to teach the people around you, to empower the people around you, to empower those children that they can live a good life, and teach them what you used to do. And my recommendation also to our community at large, especially the government. For you, the government, here is what you can do. You can make sure that our hospitals are well taken care of. And it is really, and for all of us, if the government did not do it for all of us, because sometimes we throw lavish parties. In those parties, the money that we use for those parties, we can decide, you know what, I'll sacrifice the party. I'll sacrifice and announce it, so people maybe don't laugh at you that you're doing a party that is cheap. Announce it that I am, and let somebody start it, please. I beg you, all of you of South Sudanese over there, around the world and everywhere, and especially in South Sudan. If you are doing a lavish party, you are spending too much money in stuff. Try, this is how the first world is. The first world is built on people making donation to help those who are unable, because I'm sure the treatment some people may not be able to afford the treatment. So if you sacrifice and make a donation, come make a public donation. And for you, the radios and the TVs, ask people, bring people in who are able to do donation to the hospital. Ask them to come in to the TV and let them do their donation. You will see how things will pour out. And for the government, you need to have some kind of incentive for people who will do good things in the community. Make sure that you build them up, like the doctors who are doing good things. There are doctors who goes all the way to help the patient. Make sure that you have something, you have to announce, you have to talk about them, you have to raise the hope that what they are doing is actually working. So also for us who are out here, I'm sure we didn't do good either. So I'm not gonna say it's only the people in Africa. For us who are outside also, we didn't do good either. But most of our people outside, they raise money and they send it back home. Some send medication. So make sure that you guys properly use them, properly being used, not to be sold. They are meant for the people who cannot afford it. And this is my recommendation for our people there. I'm
Thank
not
you, Dr.
I'm not I'm not trying to offend anybody, but I'm trying to talk about us in general, because us, we are people of a family, but it is time to become people of the whole community. Because if my family is hurting, I will try immediately and get the money where I can get it and go and put it there. If my home inside is not clean, I'll clean it, but I will not clean outside on the street next to my home. And this is how we are. I'm not going to clean the street in front of my house. I will only clean inside. I will not take care of part of the street in front of my house. It's time for us to imitate the outside world and come out and try to do. And I hope that we meet together, not at this time, but we can meet to talk
as doctors.
Yes.
Together, but not in life, but as doctors. Thank you very much.
Sarah, thank you. Thank you for emphasizing the importance of being the change that we want to see in the world and taking the responsibility upon ourselves and not just saying, okay, the government will do that. When we're cleaning our houses, we clean inside and we also clean the street that's next to our houses. And it is our responsibility collectively to make sure that things change and that we prioritize the health of our population in whichever way we can. We send the help. So, Dr. Kiden, challenges and recommendations, 2 minutes. Thank you. Sorry, Dr. Kiden, we can't hear you. Please unmute yourself. Thank you.
All right. Sorry for that. Thank you, everyone, for the contributions that you have been making. Indeed, I want to emphasize at this point that we all know the importance of mothers in our lives, both the men and the women that are listening to me, and therefore protecting them from morbidities and mortalities that are not warranted for them because of these chronic diseases or pregnancy-related issues. Please, even as we go out there, please make sure that you protect the mother from disease or from death because it is catastrophic to the family and catastrophic to the nation. We all know that fact very, very, very well. So what are the challenges that we face when we are treating these mothers with chronic illnesses and yet they have pregnancy? Pregnancy itself is a stressful condition for the body. Already, if your body is stressed with the conditions like diabetes, hypertension, asthma, and the alike, it usually poses a very great challenge in controlling these conditions in pregnancy. Therefore, what should we do as women? We are the custodians of our own health. Ensure that you improve on your health-seeking habits. Don't wait until things go to the other extreme before you wake up to go to the hospital. Make sure that you go for ANC screening. That, and I don't know how much I can say about it because it is the gold standard. That is where things begin. That will be able to manage your pregnancy and deliver a healthy baby. Because at the end of the day, we need these babies and we need ourselves to take care of these babies that we have brought forth. Then, secondly, it is very, very important. We have said that your condition, which is diabetes, hypertension, whatever chronic illness that you have, you must make sure that you don't conceive without planning for it because it is a high-risk pregnancy and therefore it will require your time, it will require your finances, and it will require being stationed near the doctor all the time. Therefore, do not get pregnant unless you have planned for it, unless you have discussed with your doctor, you have discussed with your husband. Make sure that you do family planning if you are to make sure if you are to sail through the pregnancy successfully, right? So make sure that you do family planning. That's very, very important to plan for the pregnancy. You don't just wake up and you all of a sudden you're pregnant. Please make sure that you don't do that because you may not sail through. Or even when you sail through, you may lose that baby because chronic illnesses tend to dispose you to abortions, miscarriages, so many complications that can come from that pregnancy in addition to what you already have. Now, to our government, the Ministry of Health, and to the health workers, please make sure that we are available for our patients. There is nothing that we are going to be doing there when we watch people die, when we are not doing anything. Why are we in the positions of responsibility if we cannot take good care of our mothers? Particularly, I will talk about the mothers because they are of importance to me. So, what do? the health worker be there for the patient. Don't be in a rush when you are seeing these patients. Make sure that you do thorough history taking, physical exam. Make sure that you pick up those conditions that will complicate that pregnancy. Don't be in a rush, right? Then the other thing is that there is no way you're going to say that we are not going to do research to provide data for us to make informed decisions. Even at the level of the government, we cannot be continuing to be blind. We misappropriate funds, and yet the mothers of the nation, the backbone of the family, they are dying in pregnancy-related conditions. Therefore, please make sure that what should you do? Avail for us data, you health workers. Even as you take those blood pressures, even as you take that blood sugars that you have, even when you do the asthma screening, whatever it is, please put that data down and avail it when needed. It would be that we have not gotten researchers to bring us this data to the public display, but I want to believe that in one way or the other, that data is there. And why is it that it's not available? We cannot keep on waiting until we see our mothers die because we cannot make informed decisions based on data. And even when we are to ask for help from whoever will give us help, let us first help ourselves by doing the basics. All right? So, and then, what are the challenges that we usually face? Even as I emphasize the fact that these mothers should go to the clinic, are the clinics there? Are they functional? We have had many of our panelists mentioning that what did Dr. Linda say? Dr. Linda said something which has gone out of my mind, but it is important for us to make sure that the medicines, yes, talk about medicines, not there. We have challenges in providing these mothers where to go to get the medicines from, and that how do we help? Sometimes the health workers want to help these mothers, but our hands can be very much tied that we cannot help out. We can see a mother coming in with convulsions. We don't have magnesium sulfate to control those convulsions. We don't have medications to bring down the blood pressures. We don't have mechanisms of delivering this mother as urgent as it is required. So we have challenges. The government, please look into it, or the Ministry of Health provide for us the resources that we need such that we can help the community that is out there waiting for our hands. Secondly, we are also faced with a major problem of referral systems. Sometimes you're in your clinic, you can see that this mother is in danger, you cannot do anything, you need to refer them to Juba Teaching Hospital, and she will look at you and say that, Daktari, unless you provide me with a means of transport, and if I go to Juba, I don't have anything to do, and if I go to Juba, I don't have anywhere to stay. And at the end of the day, we are so stuck, and we see patients die in our hands, heartbreaking. So if you are there in a position of responsibility, improve our referral systems. Please, 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 and that will be very, very wonderful for us. And then, well, we can't reach there in the referral system or to the referral site. Juba Teaching Hospital is the highest place we can go, and medicines are not there. Right? It's heartbreaking. It's heartbreaking, right? Me particularly, because I have very high interest in mothers, it is very, very, very painful to see a situation where it goes to the extreme and the mother is dying, and simply because your hands are tied. Watching a woman or a mother dying to pregnancy-related issues. Lastly, collect data. Collect data, please. We can't be blind any longer. I would think that much as we keep saying we are young and we don't have ABCD, unless we throw out that mind that we are young yet, youngest nation in the world, we keep saying that, it is no longer a pride anymore. It is working against us. Let us work very hard and we mature very fast because our problems are many. Right. Thank you very much, ladies, for having me.
Thank you, Dr.
Lastly, maybe let me just mention one thing, that COVID-19 has been, as Dr. Jane was saying, pregnancy has been proven to have an increased risk, predisposing you to worst forms of COVID-19 infection. And so for now, I would think that let us be careful when we are pregnant and make sure that you do the recommendations that your Ministry of Health has provided for you to follow. Make sure that you do your mask. South Sudan, apparently, we don't have really a lot of data on COVID-19, and make sure that you do what? You follow those recommendations. Pregnancy itself has been proven that it is a major risk factor for severe forms of COVID-19. Severity here means being hospitalized, being taken to an ICU, being intubated, and death at that matter. And so make sure that you are safe, follow the instructions. You don't need to go out when you don't need to. Thank you very much, ladies. It has been a great pleasure to have you and to contribute in this forum.
Thank you so much, Dr. Kim, for representing our mothers there. And I think you have sort of summarized most of the things we're talking about, most of the things that our panelists have talked about. The importance of collecting data and statistics in order to guide our policies and to guide how we decide on our services and its distribution. The importance of improving our service provision and being there for our patients and having the medications that are necessary to treat these conditions. The fact that we should take it upon ourselves, this is a collective effort, and we should take responsibility for this. So the government, individuals, those who suffer from these diseases, the doctors, the healthcare workers, it is a collective effort, and we should also take responsibility. And I want to thank you also for mentioning COVID-19, the current pandemic that we are currently experiencing, and the need for protecting ourselves and also protecting those who have chronic illnesses from COVID-19, because they are the ones who are severely affected. So as we come to the close of this session, I would like to thank all our panelists for taking their time to share their experience and knowledge on this platform. And I would also like to thank our audience for joining us from all the social media platforms. We would also like to thank UN Women for their support and Aisha for the technical support behind the scenes. Feel free to join us for our next discussion on the South Sudanese Women Intellectuals Forum, and we hope to see all of you again in another panel discussing health issues. Thank you so much. Thank you and goodbye. Thank you.